Hello and welcome. This is Dr. Ignacio School today with a presentation on schizophrenia. So let's go. So this is a picture of a cat drawn by a schizophrenic artist. This was in the beginning before he had any symptoms of schizophrenia, and the picture goes on as his thought processes become more severely affected, and in the end is the end result. So we're going to look at some clinical vignettes. This is a case of a young person with schizophrenia. A previously healthy 20 years old student had been behaving in an odd way. At times he appeared angry and told his friends that he was being persecuted. At other times he had seemed to be laughing at himself for no apparent reason. For several months he had seemed increasingly preoccupied with his own thoughts. His academic work had deteriorated. When interviewed he was restless, suspicious, and exhibited odd mannerism. He described hearing voices commenting on his actions and abusing him. He believed that the police had conspired with his university teachers to harm his brain and interfere with his thoughts. He also suspected they could read his thoughts. So in this case, you can see multiple symptoms of schizophrenia are present, like the persecutory delusions, his abnormal affect, and then there is also his thought disorders are present, and his deterioration of his daily work. And then his interview also, his mannerisms are odd, there is suspiciousness, and there is also auditory hallucination, and there is also delusion, persecutory delusion. On the case 2, this is a case of chronic schizophrenia. A middle-aged man lives in a supported hostel and attends a sheltered workshop. He spends most of his time alone. He is usually disabled and unshaven and cares for himself only when encouraged to do so by others. His social behavior seems odd and stilted, his speech is slow and his content vague and incoherent. He shows a few signs of emotion. For several years this clinical picture has changed little except for brief periods of acute symptoms which are related to upsets in the ordered life of the hostels. This is a case of chronic schizophrenia, where the symptoms are absent. So what is the pathophysiology of schizophrenia? The dopamine hypothesis attempts to give the pathophysiology of schizophrenia. It states that there is increased dopaminergic activity in the mesolimbic pathway, there is dysfunction of the mesocortical pathway. This overactivity of the mesolimbic pathway gives rise to positive symptoms, the symptoms which are added into the personality, and mesocortical pathway dysfunction gives rise to negative and cognitive symptoms, means symptoms which have been subtracted from the personality, and there is also abnormalities of the glutamate system. About the history, Emil Krepin first attempted to divide psychosis into dementia praecox, which later became known as schizophrenia, and manic depressive psychosis, which later became known as bipolar affective disorder. Eugene Bleuler first proposed the name schizophrenia, which means splitting of function. Schizo means splitting and phrenia means function. So this means the splitting of function. The thought, the emotion, and his activity are disconnected from each other. So he also gave 4A as the cardinal symptoms of schizophrenia. A for affect. There is blunting, flattening, and incongruity of affect. Affect is not equivalent to the underlying mood. And associations. There is a thought disorder. There is dissociation of thoughts. And there is also ambivalence. There is lack of motivation from of day-to-day activities. And autism. There is social withdrawal and failure of the theory of mind. Schneider gave first-rank symptoms of schizophrenia, which are hearing thoughts spoken aloud, third-person hallucination, a running commentary on one's action. Third-person hallucination means the person hears voices arguing, thought withdrawal, thought insertion, and thought broadcasting, which are clear. And there is also made volition, made affect, made impulse. So he thinks that his volition, his act, his affect, and his impulse are made. It is they are not real. Delusional perception. A schizophrenic patient will see a normal thing and result in a delusional perception. Like when someone coughs, he thinks that the person coughed because they think he is gay. And somatic passivity. So what are the symptoms of schizophrenia? The positive symptoms are which is added to the personality. So delusions means the person has firm belief in false facts which is held despite the evidence to the contrary and which is not explained by his socio-cultural background. Hallucination means the person has perception without the presence of external stimuli, and there is disorganized speech. And in negative, what are subtracted from the personality. Flattened affect, there is reduced speech, and there is lack of initiative. So the ICD criteria, these three are a must. So G1, in G1 there must be one symptom from the group 1 or two symptoms from the group 2, and the symptoms must have lasted for at least 1 month. On the G2, the patient should not have manic or depressive symptom, or if he has this symptom, the schizophrenic symptoms must have been present before the manic or depressive symptom. And G3 is that the symptoms are not attributable to organic brain disease or alcohol or drug related intoxication. So from 1, at least 1 should be present. Thought echo, thought insertion or thought withdrawal or thought broadcasting. B is delusions of control, influence or passivity, clearly referred to body or limb movements or specific thoughts, actions or sensation, or delusional perception. Number C is hallucinatory voices giving a running commentary on the patient's behavior, or hallucinatory voices discussing him between themselves, or other types of hallucinatory voices coming from some part of the body, example teeth or his limb. Number D is a persistent delusions of other kind that are culturally inappropriate and completely impossible. Example, the person thinks that he is able to control the weather, he is in communication with aliens from the other world, etc. Or at least 2 of the following symptoms should be present. A persistent hallucination and immodality when occurring every day for at least 1 month when accompanied by delusions. So there are both hallucination and delusions. The delusions may be fleeting or half-formed without clear affective content or when accompanied by persistent overvalued ideas. F is the neologism, breaks in the interpolation in the theory of speech, resulting in incoherence or irrelevant speech, that is, nice smooth thinking. So these are the disorders in the speech. The G is catatonic features like excitement, posturing or waxy flexibility, negativism, mutism, or stupor, all features of catatonic schizophrenia. Number H includes negative symptoms like marked apathy, paucity of speech, blunting or incongruity of emotional response. It must be clear that these negative symptoms are not due to depressive or neuroleptic medication. The DSM-5 criteria is much simpler. 2 or more of the following for at least 1 month. Delusion, hallucination, disorganized speech, grossly disorganized or catatonic behavior, or negative symptom. Impaired level of functioning in 1 or more domain. Continuous sign of the disturbance for at least 6 months with the above symptoms for 1 month. So this does not meet the criteria for schizoaffective disorder or a mood disorder with psychotic symptoms. This is not attributable to substance abuse or another medication. So this is the DSM-5 criteria.
Look at their eyes. Look at them. Their eyes are full of disgust.
You have the way.
You smell. You are disgusting. They're looking at you and seeing you, and they see everything you do, and you are disgusting. Disgusting. Hey, stop it! Stop it now! Don't touch that. Stink. Stinky.
So what about the epidemiology of schizophrenia? The incidence is usually 0.24 per 1,000 population. Lifetime prevalence is 7 per 1,000 population, and the age at onset is from 15 to 54 years. So there are 2 peaks. It occurs around 20 years for males and around 33 years for females. So what are the risk factors of schizophrenia? Being male. Genetic factors include single nucleotide polymorphism in many genes, maternal malnutrition, maternal infection, birth complication, urban birth, ethnic minority, only cannabis use, high emotional expression in the family, winter birth, paternal age more than 50 years, lower social class. So we're going to talk about the subtypes of schizophrenia. Paranoid schizophrenia, in which persecutory delusions which may be systematized are present. So if the person thinks that he is being persecuted by the FBI. And the persecutory auditory hallucination. So hallucination is usually related to the delusion itself, so he will hear the voices of FBI agents. The personality is well preserved, and thought disorders and negative symptoms are not that prominent. About the Hebephrenic or disorganized schizophrenia, it occurs at younger age, and thought disorder and affective symptoms are more prominent. So negative features are more prominent. There's silly and unpredictable behavior, the mood is variable, and there is fleeting, unsystematized delusions and hallucinations. They are unsystematized, there is no system in them. There is rambling, incoherent speech, there's negative symptoms occur early, and the prognosis is poor. What about catatonic schizophrenia? It is characterized by catatonic symptoms like waxy flexibility, mutism, or stupor, or sometimes varying to restlessness. And there are oniroid or dreamlike states. The patient is in a dreamlike state. So what are the treatment? There are atypical antipsychotics or second generation antipsychotics or classical antipsychotics or first generation antipsychotics. The atypical antipsychotics are clozapine, olanzapine, quetiapine, risperidone, ziprasidone, zotapine, sertindole, aripiprazole, and paliperidone. And the classical or first generation antipsychotics are clopramazine, vericiguine, trifluperazine, prochlorperazine, haloperidol, flupentazole, zuclopentazole, and sulpiride. So the mechanism action of these drugs. So in schizophrenia, we told that there is increased dopaminergic transmission in the mesolimbic pathway. So the antipsychotic drugs will decrease the dopaminergic neurotransmission in the mesolimbic pathway, but it will also decrease the dopaminergic transmission in the nigrostriatal pathway and the tuberoinfundibulal pathway, leading to Parkinsonian symptoms, extrapyramidal motor symptoms due to blockade of dopaminergic activity in the nigrostriatal pathway, and due to blockage of dopamine activity in the tuberoinfundibular pathway, there will be hyperprolactinemia. So this is a simple chart showing how the antipsychotics should be used in schizophrenia. It is a bit blurred, so I'll tell you. You should consider major suicide risks, metabolic issues, because in obese patients, the atypical antipsychotics cause more metabolic problems, severe agitation or violence, non-compliance, depression or mood symptoms, substance abuse, prodromal or first episode, and catatonia. So if you do monotherapy, you should do monotherapy with 4 to 6 week trial of usually atypical antipsychotics if available, like aripiprazole, olanzapine, quetiapine, risperidone, or ziprasidone. Or if they are not available, especially in poor countries or remote areas, haloperidol or clopramazine can also be used. So after 4 to 6 weeks, there is no resulting decrease in the symptoms, and if it is not efficient, so we'll change to another drug. So we'll change to another second atypical antipsychotics and use it for 4 to 6 weeks. So if 2 antipsychotics fail, then we'll use clozapine, which is a very efficient drug in schizophrenia. We'll use clozapine up to 900 mg per day for a 6-month trial. So what are the side effects of antipsychotics? Extrapyramidal symptoms due to blockage of activity in the nigrostriatal tract are dystonia, oculogyric crisis, and Parkinsonian syndrome. Akathisia, which just means restlessness, and tardive dyskinesia, tongue protrusion, lip smacking, rotational tongue movements, facial grimacing, and chorioathetoid movement of the head and neck. The tardive dyskinesia are involuntary, and these side effects are more common with the classical antipsychotics. So another side effects are anti-muscarinic side effects like dry mouth, urinary retention, constipation, exacerbation of glaucoma, and confusion. Cardiovascular side effects include postural hypertension, QTc prolongation, arrhythmias, and hyperprolactinemia, which causes gynecomastia and galactorrhea, as well as sedation. These side effects are also more common with the classical antipsychotics. So other side effects are weight gain. Weight gain is usually more common with the atypical antipsychotics or the second generation antipsychotics. Seizure, interference with temperature regulation can lead to neuroleptic malignant syndrome, screen problems, sexual dysfunction, retinal pigmentation, corneal and lens opacities, blood dyscrasias, osteoporosis, and jaundice. So is clozapine the ultimate weapon? Clozapine is useful for treatment-resistant schizophrenia when 2 antipsychotics have failed or severe treatment-related extrapyramidal symptoms, but it causes agranulocytosis in 2% of patients. So strict monitoring of blood count is required, and clozapine can also provoke seizure in 3 to 5% patients at 600 mg per daily dose. So what is the role of electroconvulsive therapy in schizophrenia? It is very useful for catatonic stupor. It is very useful if there are severe comorbid depressive symptoms and if there is severe behavioral disturbance. Thank you. The references are Oxford Textbook of Psychiatry 7th edition, DSM-5, ICD-10, Kaplan and Sadok's Synopsis of Psychiatry, and Bennett and Brown's Textbook of Clinical Pharmacology. Please subscribe, and thank you for watching Ignacio Scoli.